far. Okay. Is this it? Yep, there we go, there's our pump. So, what do we have on this end?
This is the sternal end. The other side is the it's not the lateral. Is it the lateral?
What part of the scapula is this?
AC joint.
Oh, another. Okay. Yes.
AC joints. So what does the A stand for?
Acromion.
Acromion, yes. So, sternal end, acromial end, and I'm gonna take my central ray and stick this right in between. Is this the acromial end? Not like the AC joint should go up a little bit further. Sorry, okay, there we go. So, slide over. Oops, sorry, wrong way. Slide towards me. Keep going. Slide towards me. Keep going. Small step, small step, small step. Okay. All right. So here's my central ray. All right. Looks between acromion and coracoid. All right. Great. Oh, sorry, acromion and sternal end. All right. And then height-wise, I can feel the bottom of the clavicle. I can feel the top of the clavicle. I'm just going to take this and raise it so it's right here in the middle. Oh, so right there in the middle of the shaft. Make sense? Since I moved my central ray, I'll move my IR as well. Oh, all right. Let's double check. Since your patient moved, let's double check. Still look about in the center. Just slide towards me a tiny bit. There we go. Right there in the center. Okay. So we are centered in mid-clavicle now, correct? Okay. From here, all we're going to do is collimate in. So we can collimate in this way, right? Just a little bit, right? Just enough so that we leave about an inch of light to the joint. You don't want to go too far or else you risk cutting off the ends of your clavicle. Good. And then this way, we're going to collimate in like this. So once again, don't collimate too tight. You don't want to clip the top or the bottom. So this is the acromial end. And down here is the sternal end. Just want to make sure it's open enough to where I don't clip the sternal end and I don't clip this acromial end. So leave about an inch of light in all directions. Which clavicle is this?
Left.
Left clavicle. So, left marker. Now, what did I need to double check? Clavicle, all right. And now for this clavicle, we are going to suspend this time on inspiration. So take a deep breath in, hold your breath, X-ray, breathe out and relax. We suspend on inspiration. So this is your normal AP clavicle. Any questions? Good so far?
Yes.
Okay, now remember, with all anatomy, we said we need 2 views.
Mm-hmm.
So we do have a straight on view of this clavicle where we're just centered mid clavicle, but we need something more than just an AP. Now, can we get a lateral clavicle?
No.
Probably not, no. So what can we do instead? How can we see this clavicle from a different angle?
Angle the tube.
That's right, we are literally gonna angle the tube to see this clavicle from a different angle. So we are gonna do an AP axial clavicle. The angulation for the AP axial clavicle is 15 to 30 degrees. The more hyperstenic your patient is, the lower your angle. The more asthenic your patient is, the higher the angle. So, what kind of body habitus do we want to call Samantha right now? just as an example.
Hypersthenic.
All right, so let's pretend that Samantha is hypersthenic. In that case, what kind of angle do you think I would use? Remember, my range
Lower.
is 15 to 30.
About 25.
Remember, the more hypersthenic, the lower the angle.
Oh, well, 15.
That's right. So if Samantha was hypersthenic, I would use a 15-degree angle. What if Samantha was asthenic? What angle do you think I would use?
30.
30. Very good. Right, and then your asthenic and hyposthenic, right, those would be somewhere in between. But the idea is the more hypersthenic, the less angle you have, the more asthenic, the more angle you have. Now, right now, our angle is 90 degrees. If we angle an additional 15 degrees, what should our reading say?
You said more?
So we angle
Like
an additional
105?
15 degrees.
Like 105?
105, perfect. So, assuming Samantha is hypersthenic, let's angle 105. So once again, I'm going to check for that clavicle. Pardon me. Okay, sternal end, acromial end. Okay, slide towards me a bit. Good. So get you right in the middle first.
Yes.
And now look for that shaft.
So this is read it at the regular one. This is like a, what is this position called? AP?
Right now, this is AP axial
Axial.
clavicle. So once again, I'm centered in the middle of the clavicle. Here's the sternal end. Here's the acromial end. Okay, I'm in between. But this time, here's the top of the clavicle shaft. Here's the bottom of the shaft. Notice that I'm not aimed right in the middle of the shaft. Do you know why?
Because we're trying to open that space. No. The tube is angled?
Because the tube is angled. So I want you to just take a look over here. Samantha, you can look as well. So imagine this is your clavicle, right? Your clavicle is nice and round, right? Looks like this. Right? And here's the central ray coming into the clavicle. AP, you can come here, right? Mid-clavicle, no problem, correct? But what if I kept centering here when I angle? Is this still going to show me mid-clavicle? Does this look mid-clavicle to you?
No.
I was gonna say yes, to be honest, but
It's skimming the top of the clavicle right now, right?
oh,
Mhm,
okay.
yes.
Even though we're entering here, we're going to only skim the top of the clavicle. If we want to go mid-clavicle, we actually need to aim down here.
Okay.
Oh, okay.
Go through
So
the
go
center.
through it.
Okay.
So that is why I am now aiming lower. If this is the shaft, I am aiming toward the bottom of my shaft.
Okay.
That way, because of the angle, it's going to go through the middle of the clavicle. Does that make sense?
Yes.
So AP, sure, go straight dead on in the middle, but on your angles, aim a little bit lower than you would expect. All right, in this case, keep my collimation, plot my marker up here, and deep breath in, X-ray, breathe out, relax. That is our AP axial clavicle. Okay. So just remember, angle should be between 15 to 30 degrees, and the more asthenic your patient is, the bigger your angle, the more hypersthenic your patient is, the lower your angle.
And that's because
That's because of how the body shape projects the clavicles.
okay.
Right, so for someone asthenic, right, really flat like this, clavicles are kind of like this, you need more angle to throw the clavicles up.
Okay.
Right, if the clavicles are already kind of like curved outwards on your hypersthenic patient, you don't need as much to pop the clavicles up.
Okay. Cool. Okay. That makes sense.
All right, great. So that's
So what about in like a hyposthenic?
So hyposthenic, maybe like 25 degrees. Sthenic, maybe 20 degrees.
Okay.
Just is larger.
So for test out if we are anywhere in between, is that okay? Well, you said 15 to 30.
So for test out, as long as it's not egregious. So let's say that
Is it okay if we stay in the middle?
let's say that you were the patient, right? and it was 15 degrees, I would have some questions,
Okay.
right? If it was Jamaica and it was 30 degrees, I would probably have some questions,
Okay.
right? But if it was 20 degrees or 25 degrees, I'd be more like, okay, yeah, I can see that,
Okay, shoot somewhere in the middle.
right? So yeah, if you want to play it safe, probably aim somewhere in the middle.
Yeah, I'm gonna do that.
So for her, she'll be like 15.
So for Regan, I would probably go closer to 30 because more aesthetic.
You want to do that
Hmm?
at the top? Is it?
It
Is it
went
still?
away.
Oh, your battery.
Oh,
It
my
said,
battery?
yeah.
Oh my gosh, 15%. Oh, this thing's burning up.
Yeah,
Wow.
it said if you turn it on, your battery saver, if you want to say.
All right. Is it because I'm not? Oh, was I not on Wi-Fi? Is that why?
Mhm. I know it burns fast. That battery burns fast when you record.
Shout out my bags.
Ooh. Huh?
One more clavicle.
That was it for clavicle.
Oh,
For the regular.
But we do have AC joints. All right. Okay. So let's talk about AC joints. AC joints are here and here, correct?
Yes.
They're like basically opposite ends of the body. However, when we do AC joints, we want to catch both AC joints at the same time. That's right. We want to be able to compare the AC joints. Because the idea is that very rarely will both AC joints have separation or dislocation. Usually it's just one or the other. So we want to see if one of them has a wider gap than the other one. We want to catch both of them on the same picture. But to get something this far away, what kind of cassette do you think we need?
14 by 17.
14 by 17 positioned how?
Crosswise.
Crosswise. That's right. So we are going to switch over to a 14 by 17 crosswise. Thank you. Thank you.
Which one is the one that has the 72?
This is also the one with the 72. Very good, very good. So, not only are we going crosswise like this, but because this is almost like a chest, we are going to take this and pop this all the way back to 72. Or, in this case, 71.
Why is that a 71?
That's just how the machine was installed.
Oh.
Like I ain't got time for that.
It's a GE thing. Okay. Alright, so I've got my nice 72-inch SID. I've got my nice 14 by 17 crosswise. I'm going to take my patient, put them flat against the board, slide them over towards me so that they are MSP. Very good. Oh, and more.
I saw this. I said, Rick, why are you drawing this?
So, right, AC
I thought
joint,
it's on the table.
AC joint, both of these are inside my light field, correct?
Mm-hmm.
I'm going to take my height and bring it up to those AC joints. And so, set AC joint was right there, right? Same height as the AC joint. And now I am going to collimate.
You can't really comment too much, right?
So, correct, left to right, I can't really collimate, but I can definitely collimate up and down because AC joints are just tiny thing right there. And of course, I leave myself enough light to mark. In this case, because I am doing I'm looking at two separate joints, I do prefer to use two separate markers. Oh my gosh, I almost forgot. Every time you move the central ray, what do we do?
Move your
Move. That's right, move our IR. Okay, back facing. Thank you. That's right, tisk, Mr. Film. Almost made a fatal mistake. 5 points off. Okay, so I've got my markers here on the IR now. And this would be my AP AC joints
Without weights.
without weights. Very good. But we do have a second image, don't we?
Mm-hmm.
We do have to do a second X-ray with weights. So let's come over here.
Is there breathing for this?
Oh, yes, there is breathing for this. Let me double check. It's been a while since I did AC joints. It is suspend respiration.
Okay.
So just hold your breath, X-ray. All right.
Those look heavy.
So we've got weights here. These should be about 3 to 5 pounds. Okay, so it shouldn't be too much. And the idea here is that we're going to try and wrap it around the patient's wrists if possible. Right, so maybe just something like something like this.
Okay.
Wrap this around. Got that? All right. Try and just relax the arms, right? Because we don't want them to grip or grab the weights, right? If they grab, they tense up,
Mm-hmm.
and now you can't see these separate. So they leave it nice and loose, so that we can let gravity pull both of these AC joints down. So you do this, quickly step back, hold your breath, X-ray, and then come back and relieve the patient of their weights. Now, let's say that you can't hang them on the wrist. Something else that you could try and do is just have them hold it with their fingers loosely, right? That way, once they they're not clenching, right? You're just kind of like letting it hang on the fingers. So just make a hook with your fingers. Yeah, just make a nice little hook. Got it. Good. So nice and relaxed. Just hook your fingers, nice and relaxed. Just leave that kind of loose. Loose. Don't try not to grip it. Very good, right? So just leave the fingers kind of hooked like this, and just hang the bags on those fingers. Okay, so perfect. Looks great.
You have a charger in your car, right?
I do, yes.
Okay, I was gonna say I don't want you riding around with it. Okay.
It would be bad riding around with a dead phone. I agree.
Yeah.
Hopefully we are able to keep Emily on the line long enough to finish this up. So, All right, we have
11.
just 3 more views to go over. So, let's talk about the scapula. Okay, so relax for now, Samantha. Scapula is gonna come back to a 40-inch SID.
Where's the one that they said the IR doesn't match they said there was one that the IR didn't match up with the tube or something
Yes,
like
that is correct. That is the very last one we will do. It is our second Lawrence method, also known as the infero-superior axillary.
So they both called the Lawrence method.
Yes, there are 2 Lawrence methods. Mr. Lawrence was very prolific.
He was busy.
He was busy, yes. But not in that way, in the other way.
You have nothing to do.
Well, actually, I don't know if he was busy. He was busy both ways. Who knows? Okay.
Ridiculous.
So, for the scapula, if you take a look at our light, this is 10 by 12 again, and this is lengthwise. Okay. The idea here is that with our scapula, where do we center for the shoulder? Do you remember?
1 inch
in
inferior.
the humerus, and then
And 1
inferior. 1 inch inferior to the
No,
clavicle.
Coracoid.
Yes,
Coracoid.
1 inch inferior to the coracoid, which is just slightly medial to your humerus, just slightly inferior to your AC joint. Good. So 1 inch down from the coracoid. For the scapula, you're going to go 2 inches down from the coracoid. Right. So just like your shoulder, but a little bit lower. But here's the fun part about the scapula. The arm, instead of leaving it down, you are now going to ask the patient to do a stop sign. Right? Halt.
Higher.
Nope.
Higher.
Not a lazy stop sign.
Oh, okay.
That's right. We gotta do a full-fledged, all the way out to the side stop sign.
It's like a 90 degrees. Hold the arm.
This humerus has to come 90 degrees. It has to come straight horizontal. Now, what happens up here is not important. So you can do stop sign, you can do salute, right? Right? Salute, right? Doesn't matter. You can do whatever you want with the upper arm, but the humerus needs to come up. Okay? And then from here, I'm gonna look for that coracoid, which is somewhere around here. I'm gonna drop 2 inches, so somewhere around here. And that is gonna be our centering. At least for the height. Now, lateral medial, our centering is gonna be the side of the patient, and then, sorry, let me double check. Okay, 2 inches, good. So side of the patient, and then 2 inches medial. Now, I'm not gonna try and palpate that on my patient like this, right? On a male patient, you might be able to get away with it. On a female patient, not so much. So instead, what I'm gonna do is I'm gonna find the side of my patient, okay, figure out where it is up here, and do my 2 inches from the top, right, rather than down there by the side. So, Samantha, I'm gonna slide you a little bit to your right. Perfect, just like that. So, 2 inches down from the coracoid, and 2 inches medial from the side of my patient. Does that make sense?
Mm-hmm.
Arm is up. Just collimate in a little bit so that we don't have light here. Collimate this way. Leave just enough room for a marker. Which arm is this?
Left.
Left. Great. So left marker goes here. And now we need to make a choice as to how to do our breathing instructions for this scapula. Okay, so if you want a good AP scapula, you will notice that we need to shoot through the lungs. How do we get rid of the lungs from an image?
Breathe in.
That's right, short, shallow breaths, in and out, in and out. X-ray, yay, 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 yay. Okay, breathe and relax. So orthostatic breathing, that is the optimal way to shoot the scapula. But what if the patient cannot do orthostatic breathing? In that case, I'm gonna.
Sorry.
In that case, I'm gonna double check with them because I want to make sure I'm saying the correct thing. It's been a while. AP scapula respiration. So, nope, that's coracoid process. No, that's AP oblique. That's lateral. AP.
I said orthostatic breathing really sounds like something we need to know first.
All right.
Mhm.
Actually, they don't even have another option to orthostatic breathing. They just say, do it while the patient's breathing.
So you'll just tell them, to breathe in,
So in that
breathe out,
case-
and just watch them as they breathe in.
Yes.
Okay.
So in that case, just don't even tell them instruction. Just be like, all right, just breathe normally. Just watch them breathe and just be like, here, X-ray.
So is it still the long one?
So long one if you can. Otherwise, you can just shoot normally.
Okay.
So some machines you can set to be really long. Some machines don't have that ability.
Okay.
Just whatever equipment you're working with. All right, sorry Samantha, you can put your arm down. Thank you. And now the final thing for the scapula, the lateral scapula, which is also a scapular Y, but this time not trauma. So, Samantha, I'm going to have you turn around, face the board. Okay, spin the shoulder around as well, please.
Did you used to use your pen with patients?
Mm-hmm. Or I either use my pen or I use my finger. So I do like this with my fingers. Okay, great. So touch the board. So once again, just like with the shoulder Y, we are going to turn our patient. So we'll look at the right shoulder, which means we bring the right shoulder nice and close. But now there is a change. Because this is not trauma, we are free to move the affected arm, correct?
Yes.
there are two ways to do the scapula. You can do lateral scapula for the body of the scapula, or you can do lateral scapula for the acromion and coracoid of the scapula. In lab, we are only going to do the body of the scapula. Okay? So to do the body, we're going to ask the patient to take that affected arm and bring the hand across to touch the opposite shoulder. So right hand onto your left shoulder, please. Good. Bring your elbow down. Yep. And this is the position for lateral scapula body. On the other hand, just in case you were doing acromion coracoid, you would take this arm and you would put it behind the back instead.
I think Emily, she said I haven't been able to see for like 10 minutes.
Well, she's got the video. She's got the video.
Oh, she hasn't been able to see.
Oh.
She asked his class over.
Oh, okay.
You turn your Wi-Fi off,
Is
Mr.
it
Funk?
well, it might be
or-
because my battery
Oh, your
is
battery's
so
gonna
low.
go dead.
Silly,
Yeah.
Okay, hold on. So,
She probably didn't catch the.
yes. Let me just turn this off and I'll just message her.
Okay.
Offhand, all the lab videos will be they'll be uploaded today.
This is gonna be delightful, Mr. Donnie's class. I can already tell.
So, Mr. Fun, when we spin the wheel, are they gonna be? We gonna have to spin it like we did the upper extremities, and do 3 like that? Or are we gonna do it with this as well, or?
Or wait, Shamika, you said you would send the video to Emily later?
Yeah, they'll be.
Or
all
Samantha?
uploaded. Yeah.
Oh, that's your phone.
Yeah, so she'll
Okay.
have part of it. I'll get it, and we're gonna like get it all together.
Okay.
All that they'll be uploaded by this evening. It might take a couple hours because it's a couple videos, but like
Okay.
probably by 6 or 7, I guess.
All right. Sure. All right. Sorry. So, what is the question?
With these
Yes.
exams, we gonna spin the wheel like we did for upper extremities to get 3?
Correct. We're
Okay.
going to spin 3 times. There are no mandatories. Right. So, sorry, let's get back to scapula body. Great. So, hand across the shoulder. Right. We've got the shoulder kind of close to the IR here. Okay. And now we are going to once again position for the Y. So, just like before, I'm going to slide our patient forwards. Very good. But now this time, we need to be careful because when we brought the hand across, the scapula moved. It's no longer in the normal place over here. It came more lateral over here. Right, so you normally expect the scapula here, but it slid over. Right, so here's my superior angle. Here's my AC. Okay, so I'm going to turn. Okay, sorry, let me hit the light. Thank you. Slide. Good. Open. AC. All right. So this is going to be my rotation. This rotation is going to be a bit lower. It's going to be a bit less compared to your normal shoulder Y view because the scapula went this direction. And now, centering, height-wise. So I'm centered here, nice and lined up, but as far as height goes, because this is lateral scapula, I want to make sure to get the whole scapula, which means I'm going to center mid-scapula. So I find my superior angle, follow this down, I find my inferior angle, and I'm going to go right here in between. Okay, careful Samantha, I'm just going to slide this down.
Sure.
Watch your elbow. Okay. Right shoulder, right marker, and that is my lateral scapula for the body. Does that make sense? And then of course, just want to, you can even column it in a bit if you want. Just make sure you still have the angles on top and bottom.
Okay, so from left to right is the same. As the trauma.
Correct. Just find the top, superior angle, find the AC, just line them up. Okay, great, you can relax. Thank you, Samantha. And for this one, it's just suspend respiration. Okay, go ahead and untie that. Thank you. Okay, we have one final position left, and that is the transthoracic, or sorry, not transthoracic, the Lawrence inferosuperior axillary. So, who would like to be our patient for this one?
What do you gotta do for that one?
You get to lay down on the table.
If you guys, want me to do it, so just laying down on the table and doing what? Like, I don't know, like, what do you do, just find out?
You'll find out.
You probably have to raise one arm up.
Oh, okay. Oh, okay, I know this, so this is where the board is against, the board is against the upper arm, correct?
Mmm.
Ish, kind of,
Ish, kind of,
She's like,
yes.
ish.
There we go, yes. Okay, good.
Got some sheets.
Let's get some sheets over here. Ooh, really low. Really low.
Do you have ibuprofen at your phone?
I can check my bag.
Yeah, I need something too, Mr. Fawn.
Because I'm not going to make it today if I don't take something.
You like me, I'd be like, I gotta take something, cause
Cocaine, so I'll take it.
she said cocaine. I am beat today.
I didn't drink my coffee this morning. It was all
For IR today, I didn't think I could, like, I don't know, no idea. I think all I'm gonna do is help them set up the surgical tray, then going back to the control room area. To stand up with a lead vest in, I did not have the interview for like an hour each time. So,
Yes.
I mean, I don't need to be right there anyway. So, I think I'll survive clinic today. But I just setting up the surgical tray, going clean up, and then going back to the control
If I
room.
pause this, will it resume?
I don't know, you can pause it and then I can piece it together.
Okay, so I'm gonna pause it since.
Yeah, or just stop it and you can restart